Benign thyroid diseases. History. Goiter. Thyroid function cures. First described in China in 2700 BC. Thyroid function. Da Vinci. Thyroid is designed to fill empty spaces in the neck. Parry. Thyroid works as a buffer to protect the brain from surges in blood flow. Roman physicians. Thyroid enlargement is a sign of puberty. Cures. Application of toad's blood to the neck. Stroking of the thyroid gland with a cadaverous hand. Surgical advances. 500 AD, 1200s AD, 1646 AD, 1808 AD. Abdul-Qasim Kelebis Abbas performed the first goiter excision in Baghdad. Procedure, unknown. 1200s AD. Advancements in goiter procedures included applying hot irons through the skin and slowly withdrawing them at right angles. The remaining mass or pedicle tissue was excised. Patients were tied to the table and held down to prevent unwanted movement. Most died from hemorrhage or sepsis. 1646 AD. Wilhelm Fabricius performed a thyroidectomy with standard surgical scalpels. The 10-year-old girl died, and he was imprisoned. 1808 AD. Guillaume de Puitron performed a total thyroidectomy. The patient died post-operatively of shock. Surgical advances. 1866. If a surgeon should be so foolhardy as to undertake it, thyroidectomy, every step of the way will be environed with difficulty, every stroke of his knife will be followed by a torrent of blood, and lucky will it be for him if his victim lives long enough to enable him to finish his horrid butchery. Samuel David Gross. Surgical advances. 1883. Kokas performs a retrospective review. 5,000 career thyroidectomies. Mortality rates decreased. 40% in 1850, pre-Koka and Bill Roth. 12.6% in 1870s, Koka begins practice. 0.2% in 1898, end of Koka's career. Many patients developed cretinism or myxedema. His conclusions. Surgical advances in presentation to the German Surgical Congress. The thyroid gland in fact had a function. Theodore Koka, 1883. Medical advances. 1820 AD. Johann Straub and François Coindet found that use of seaweed, iodine, reduced goiter size and vascularity. 1830 AD. Graves and von Bastow describe a toxic goiter condition they referred to as Merzberg triad: goiter, exophthalmos, palpitations. Thyroid physiology. Iodine transport. Na +/isimport protein controls serum I uptake. Based on Na+/Ga+ antiport potential. Stimulated by TSH. Inhibited by perchlorate. Thyroid hormone formation. Thyroid peroxidase, TPO. Apical membrane protein. Catalyzes iodine organification to tyrosine residues of thyroglobulin. Antagonized by methimazole, PTU. Iodine coupled to thyroglobulin. Monoiodotyrosine, Tg+1I. Diiodotyrosine, Tg+2I. Prehormones secreted into follicular space. Wolff-Chaikoff effect. Increasing doses of I increase hormone synthesis initially. Higher doses cause cessation of hormone formation. This effect is countered by the iodide leak from normal thyroid tissue. Patients with autoimmune thyroiditis may fail to adapt and become hypothyroid. Jod-Bastow effect opposite of the Wolff-Chaikoff effect. Excessive iodine loads induce hyperthyroidism. Observed in hyperthyroid disease processes. Graves' disease. Toxic multinodular goiter. Toxic adenoma. This effect may lead to symptomatic thyrotoxicosis in patients who receive large iodine doses from dietary changes. contrast administration. Iodine-containing medication, amiodarone. Perchlorate chloride inhibits the Na+I transport protein. Normal individuals show no leak of I-123 after chlor4 due to organification of I to MIT/D. Patients with organification defects show loss of RAE. Used in diagnosis of Pendred syndrome, thyroid hormone control. TRH produced by hypothalamus releases pulsatile, circadian. Down-regulated by T3. Travels through portal venous system to adenohypophysis. Stimulates TSH formation. TSH produced by adenohypophysis thyrotrophs upregulated by TRH. Down-regulated by T4, T3. Travels through portal venous system to cavernous sinus, body. Stimulates several processes. Iodine uptake. Colloid endocytosis. Growth of thyroid gland. TSH response. Thyroid hormone. Majority of circulating hormone is T4. Total hormone load is influenced by serum binding proteins. Albumin 15%. Thyroid binding globulin 70%. Transthyretin 10%. Regulation is based on the free component of thyroid hormone. Hormone binding factors. Increased TBG. High estrogen states, pregnancy, OCP, HRT, tamoxifen. Liver disease, early. Decreased TBG. Androgens or anabolic steroids. Liver disease, late. Binding site competition. NSAIDs. Furosemide 4. Anticonvulsants, phenytoin, carbamazepine. Thyroid evaluation. TRH, TSH, total T3, T4 free T3, T4A thyroglobulin. Antibodies, anti-TPO, anti-TSHR. Thyroid evaluation. RAE. Scintillation countermeasures radioactivity after I-123 administration. Uptake varies greatly by iodine status. Indigenous diet, normal uptake 10% versus 90%. Amiodarone, contrast study, topical betadine. Elevated RAE with hyperthyroid symptoms. Graves. Toxic goiter. Low RAE with hyperthyroid symptoms. Thyroiditis, subacute, active Hashimoto's. Hormone ingestion, thyrotoxicosis factitia, Hamburger thyrotoxicosis. Excess intake in Graves, Jod-Basedow effect. Ectopic thyroid carcinoma, struma ovary. Iodine states. Normal thyroid. Inactive thyroid. Hyperactive thyroid. Common thyroid disorders. Goiter. Goiter, chronic enlargement of the thyroid gland not due to neoplasm. Endemic goiter. Areas where greater than 5% of children 6 to 12 years of age have goiter. Common in China and Central Africa. Sporadic goiter. Areas where less than 5% of children 6 to 12 years of age have goiter. Multinodular goiter in sporadic areas often denotes the presence of multiple nodules rather than gross gland enlargement. Familial goiter etiology. Hashimoto's thyroiditis. Graves' disease. Diet. Early stages only, late stages show atrophic changes. May present with hypo, hyper, or euthyroid states. Graves' disease. Due to chronic stimulation of TSH receptor. Diet. Brassica, cabbage, turnips, cauliflower, broccoli. Cassava. Chronic iodine excess. Iodine excess leads to increased colloid formation and can prevent hormone release. If a patient does not develop iodine leak, excess iodine can lead to goiter. Medications. Lithium prevents release of hormone, causes goiter in 6% of chronic users. Neoplasm. Goiter pathogenesis. Thyroid function evaluation. Iodine deficient areas. Heterogeneous response to TSH. Chronic stimulation leads to multiple nodules. Iodine replete areas. Thyroid follicles are heterogeneous in their growth and activity potential. Autopsy series show MNG greater than 30%. Thyroid function evaluation. TSH, T4, T3. Overt hyperthyroidism, TSH low, T3/T4 high. Subclinical hyperthyroidism, TSH low, T3/T4 normal. Determination of thyroid state is key in determining treatment. Non-toxic goiter cancer screening in non-toxic MNG. Long-standing MNG has a risk of malignancy identical to solitary nodules, less than 5%. MNG with nodules less than 1.5 cm may be followed clinically. MNG with non-functioning nodules greater than 4 cm should be excised. No FNA needed due to poor sensitivity. Incidence of cancer, up to 40%. FNA and MNG. Sensitivity 85% to 95%. Specificity 95%. Negative FNA can be followed with annual US. Insufficient FNAS should be repeated. Inconclusive FNA or papillary cytology warrants excision. Hyperfunctioning nodules may mimic follicular neoplasm on FNA. Non-toxic goiter treatment options, no compressive symptoms. US follow-up to monitor for progression. Thyroid suppression therapy may be used for progressive growth. May reduce gland volume up to 50%. Goiter regrowth occurs rapidly following therapy cessation. Surgery. Suspicious neck lymphadenopathy. History of radiation to the cervical region. Rapid enlargement of nodules. Papillary histology. Microfollicular histology. Non-toxic goiter treatment options, compressive symptoms, ryablation. Volume reduction 33% to 66% in 80% of patients. Improvement of dysphagia or dyspnea in 70% to 90%. Post-tri hypothyroidism 60% in 8 years. Post-tri Graves' disease 10%. Post-tri lifetime cancer risk 1.6%. Surgery. Most commonly recommended treatment for healthy individuals. Toxic goiter evaluate for FNA evaluation. Graves' disease. Clinical findings, protibial myxedema, ophthalmopathy. Anti-TSH receptor AB. Higher-Aui. Thyroiditis. Clinical findings, painful thyroid and subacute thyroiditis. Low-Aui. Recent iodine administration. Amiodarone. For contrast. Change in diet. FNA evaluation. Not indicated in hyperthyroid nodules due to low incidence of malignancy. FNA of hyperthyroid nodules can mimic follicular neoplasms. Toxic goiter risks of hyperthyroidism. Toxic goiter atrial fibrillation. Congestive heart failure. Loss of bone mineral density. Risks exist for both clinical or subclinical disease. Toxic goiter. Toxicity is usually long-standing. Acute toxicity may occur in hyperthyroid states, Jod-based DAO effect, with relocation to iodine-replete area. Contrast administration. Amiodarone, 37% iodine. Toxic goiter treatment for toxic MNG thionamide medications. Not indicated for long-term use due to complications. May be used for symptomatic individuals until definitive treatment. Radioiodine. Primary treatment for toxic MNG. Large I-131 dose required due to gland size. Goiter size reduction by 40% within 1 year. Risk of hypothyroidism 11% to 24%. May require second dose. Surgery. Used for compressive symptoms. Hypothyroidism occurs in up to 70% of subtotal thyroidectomy patients. Pre-surgical stabilization with thionamide medications. Avoid SSKI due to risk for acute toxic symptoms. RAO in hyperthyroid states. Graves' disease. Most common cause of thyrotoxicosis in the industrialized world. Autoimmune condition with anti-TSHR antibodies. Onset of disease may be related to severe stress which alters the immune response. Diagnosis. TSH, T4, T3 to establish toxicosis. RAO scan to differentiate toxic conditions. Anti-TPO, anti-ZARB, FT3 if indicated. RAO in hyperthyroid states. High uptake. Low uptake. Graves. Subacute thyroiditis. Toxic MNG. Iodine toxicosis. Toxic adenoma. Thyrotoxicosis factitia. Graves' disease treatment beta blockers for symptoms. Thionamide medications may re-establish euthyroidism in 6 to 8 weeks. 40% to 60% incidence of disease remission. 20% incidence of allergy, rash, itching. 0.5% incidence of potentially fatal granulocytosis. Radioiodine ablation. 10% incidence of hypothyroidism at 1 year. 55% to 75% incidence of hypothyroidism at 10 years. Avoid RAI in children and pregnancy. Surgery. Large goiters not amenable to RAI. Compressive symptoms. Children, pregnancy. 50% to 60% incidence of hypothyroidism. Toxic adenoma thyrotoxicosis treatment indications. Hyperfunctioning nodules less than 2 cm rarely lead to thyrotoxicosis. Most nodules leading to thyrotoxicosis are more than 3 cm. Treatment indications. Postmenopausal female. Due to increased risk of bone loss. Patients over 60. Due to higher risk of atrial fibrillation. Adenomas greater than 3 cm. Toxic adenoma treatments, antithyroid medications, radioiodine surgery. Not used due to complications of long-term treatment. Radioiodine. Cure rate greater than 80%, 20 mCi 131. Hypothyroidism risk 5% to 10%. Second dose of I-131 needed in 10% to 20%. Patients who are symptomatically toxic may require control with thionamide medications before RAI to reduce risk of worsening toxicity. Surgery. Preferred for children and adolescents. Preferred for very large nodules when high I-131 dose is needed. Low risk of hypothyroidism. Ethanol injection. Rarely done in the US. May achieve cure in 80%. Hypothyroidism. Symptoms: fatigability, coldness, weight gain, constipation, low voice. Signs: cool skin, dry skin, swelling of face/hands/legs, slow reflexes, myxedema. Newborn, retardation, short stature, swelling of face/hands, possible deafness. Types of hypothyroidism: primary, thyroid gland failure. Secondary, pituitary failure. Tertiary, hypothalamic failure. Peripheral resistance. Hypothyroidism cause is determined by geography, diagnosis, treatment. Hashimoto's in industrialized countries. May be due to iodine excess in some coastal areas. Diagnosis: low FT4, high TSH, primary, check for antibodies. Low FT4, low TSH, secondary or tertiary, TRH stimulation test, MRI. Treatment: levothyroxine, T4, due to longer half-life. Treatment prevents bone loss, cardiomyopathy, myxedema. Hypothyroidism agenesis, thyroid destruction, inhibition of function. Hashimoto's thyroiditis. Surgery. I-131 ablation. Infiltrative diseases. Post-laryngectomy. Inhibition of function. Iodine deficiency. Iodine administration. Antithyroid medications, PTU, methimazole, lithium, interferon. Inherited defects. Transient. Postpartum. Thyroiditis, Hashimoto's, chronic, lymphocytic. Most common cause of hypothyroidism. Result of antibodies to TPO, TBG. Commonly present in females 30 to 50 years. Usually non-tender and asymptomatic. Lab values. High TSH. Low T4. Anti-TPO AB. Anti-TBG AB. Treat with levothyroxine. Thyroiditis. Hashimoto's thyroiditis. Most common cause of goiter and hypothyroidism in the U.S. Physical. Painless diffuse goiter. Lab studies. Hypothyroidism. Anti-TPO antibodies, 90%. Antithyroglobulin antibodies, 20 to 50%. Acute hypothyroidism, 5%. Treatment. Levothyroxine if hypothyroid. Triiodothyronine, for myxedema coma. Thyroid suppression, levothyroxine, to decrease goiter size. Contraindications. Stop therapy if no resolution noted. Surgery for compression or pain. Silent thyroiditis, postpartum thyroiditis. Silent thyroiditis is termed postpartum thyroiditis if it occurs within 1 year of delivery. Clinical. Hypothyroid symptoms at presentation. Progression to euthyroidism followed by hypothyroidism for up to 1 year. Hypothyroidism generally resolves. Diagnosis. May be confused with postpartum Graves' relapse. Treatment. Beta blockers during toxic phase. No antithyroid medication indicated. Iopanoic acid, Talopaque, for severe hypothyroidism. Thyroid hormone during hypothyroid phase. Must withdraw in 6 months to check for resolution. Subacute thyroiditis to veins, granulomatous. Most common cause of painful thyroiditis. Often follows a URI. FNA may reveal multinucleated giant cells or granulomatous change. Cause. Pain and thyrotoxicosis, 3 to 6 weeks. Asymptomatic euthyroidism. Hypothyroid period, weeks to months. Recovery, complete in 95% after 4 to 6 months. Subacute thyroiditis to veins, granulomatous. Diagnosis. Elevated ESR. Anemia, normochromic, normocytic. Low TSH, elevated T4 greater than T3, low anti-TPO/TGB. Low Ry uptake, same as silent thyroiditis. Treatment. NSAIDs and salicylates. Oral steroids in severe cases. Beta blockers for symptoms of hypothyroidism, iopanoic acid for severe symptoms. PTU not indicated since excess hormone results from leak instead of hyperfunction. Symptoms can recur requiring repeat treatment. Graves' disease may occasionally develop as a late sequelae. Acute thyroiditis causes may occur secondary to more common in HIV. 68% bacterial, S. aureus, S. pyogenes. 15% fungal. 9% mycobacterial. May occur secondary to piriform sinus fistulae. Pharyngeal space infections. Persistent thyroglossal remnants. Thyroid surgery wound infections, rare. More common in HIV. Acute thyroiditis diagnosis, treatment: warm, tender, enlarged thyroid. FNA to drain abscess, obtain culture. Rheonormal versus decreased indica veins. CT or US if infected TGDC suspected. Treatment. High mortality without prompt treatment. 4 antibiotics. Nifcillin, gentamicin or acefin for empiric therapy. Search for piriform fistulae, BA swallow, endoscopy. Recovery is usually complete.